שלום לכולם. לראות שזה עובד. Good afternoon. I'll be talking about liver cysts in the liver and mainly concentrate on non-biliary cysts which reside in the liver. זה לא נוח, אפשר להוריד את זה? מול הפרצוף. זהו.
Okay.
Okay, thank you. So liver cysts comprise a large list of pathologies. They may be simple, they may be non-simple. Most of them in the liver are from biliary origin, but I will concentrate on those which are non-biliary. And the main role of the radiologist with these liver cysts is to assess for concerning features and to suggest a differential diagnosis and mainly to give recommendations when further evaluation, investigation, and intervention should be performed. Now you're all familiar with the Bosnia classification, and you know that standardization and classifications are always useful. And with Bosnia classifications, we can easily divide renal cysts into those which are benign and those which are malignant. We divide them into two groups according to certain features such as septations, the thickness of septations, enhancing components, vascular components. But just imagine, and this is just to make a point because I'm not going to talk about renal cysts, just imagine that these cysts that you see here in the kidneys were located in the liver. It doesn't mean that a simple appearing cyst in the kidney, which is benign, will be benign in the liver. And it doesn't mean that if you see a complicated cyst in the liver, if it's malignant in the liver because of the way we categorize them, it doesn't mean that this will be malignant in the liver. So simple cysts in the liver may not necessarily be benign, and complicated cysts in the liver may not necessarily be malignant. So this is one take-home message. Now we can divide cysts in the liver into two groups, biliary and non-biliary, but another way to divide them is to divide them into those which are developmental, those which are neoplastic, and those which are inflammatory, and each one of these groups will contain cysts which are biliary and non-biliary origin. Now starting with a simple hepatic cyst. These are usually of congenital origin. They arise from remnants of biliary ducts. They contain fluid. The fluid is usually homogeneous, it's clear, and it is continuously secreted by the epithelial lining of the cyst. This causes the increased through transmission sound that we see on ultrasound. They have a very smooth, thin wall. There are no complex internal features within them, and there is no enhancement following the administration of contrast material. Puncturing them will not help you in differentiating between benign and malignant because all of them will contain a certain amount of gamma GT and CA19-9. I will show you many cases as we go through this lecture. This is a case of a patient who comes in with a cyst which is located just adjacent to the gallbladder in segment 5. It is very well circumscribed, it looks simple. This patient was operated and this turned out to be a foregut ciliated cyst. These liver cysts have a decreased signal intensity on T1 weighted. They have an increased signal intensity on T2 weighted images. The T1 signal is slightly hyperintense, although it is lower. It is low, but they're slightly hyperintense. And this is caused because these cysts contain mucin. These cysts are extremely rare, and although seen here in segment 5, they are usually located in a subcapsular origin in segment 4. And previously they were considered as benign, completely benign, but because today we know that 5% will develop squamous cell carcinoma, they are resected. This is a 34-year-old patient who comes in with an incidental finding and demonstrates a cyst located around segment 6 of the liver. It looks quite benign. This was an incidental finding. She was released. And she returns to our hospital a few years later with right upper quadrant pain, and there is a calcified stone within this cyst. She was operated, and this turned out to be a duplicated gallbladder. Now, duplicated gallbladders are also very rare. There are two types: those which have 2 chambers and 1 cystic duct, those which have 2 chambers and separate cystic ducts. There is difficulty in the drainage of bile from them, and therefore they create stones within them. And resection is usually the procedure that is performed, although it is controversial. This is a 73-year-old female who comes for routine follow-up because she has this multilocular cyst within the liver. And 2 years after her initial CT, she presents with the cyst, which has become smaller. It increased in size, and there was no enhancement. She was asymptomatic, and this was considered a hemorrhagic cyst. Simple cysts can complicate. They can get inflamed, infected, and they can hemorrhage. Since she was asymptomatic, we decided not to do anything with this cyst. She was sent home and called for follow-up. She was lost for follow-up and turned 2 years later, and probably luckily for her, this cyst even shrunk, became smaller, caused retraction of the capsule. So what this demonstrates is that simple hepatic cysts can complicate, and complication does not necessarily mean that we need to move on with an aggressive approach. Follow-up, we can follow up on them. This is a 63-year-old female who presents with right upper quadrant pain. She had multiple cysts in her liver, which are not seen on this image, but she also had this complex lesion with an exophytic component around segment 3 of the liver. This has solid features, it has cystic components, it's well circumscribed, but it doesn't have any vascularity in it, as you can see on this Doppler image. She goes for MRI, which demonstrates the multiple liver cysts that she has, but also here in segment 3 is the lesion that we saw on ultrasound. It is of high signal intensity on T1, heterogeneous, high and heterogeneous on T2, and there is no enhancement that you can see here in this subtracted postgadolinium image. So this was considered a hemorrhagic cyst. This is very typical for hemorrhagic cysts. They have high signal intensity on T1 and T2 weighted images. Hemorrhagic cysts can have a very variable and complicated appearance, beginning from completely or almost completely fluid with debris in them. They may have septations. They may have some features which look solid. They may look very aggressive, very complicated. Doppler is very useful when you encounter these cysts. So this is an example of a complicated cyst, and with Doppler, there is no vascularity seen within it. However, look at this patient. This patient came in with right upper quadrant pain, with a mass in his liver and had a central cystic structure within it. Now, there could be a differential diagnosis for this. This could be a large hemangioma with a necrotic central area. This could be a large hematoma with some liquefaction within it. This could be a necrotic tumor. This could even be, in the right clinical setup, this could be an abscess. However, we did put Doppler on it, and it demonstrated tremendous flow within this cystic structure. This turned out to be a large hepatoma with a pseudoaneurysm arising in it. So remember that Doppler is your friend. You will always want to use Doppler when you see these cystic components within the lesion. You certainly would not want to puncture this pseudoaneurysm. This is a young patient who presents with this incidental finding. There is a very simple appearing cyst in his liver. But since he originated from Eastern Europe, we decided to take serology, thinking that this, even though it doesn't really look like a Hydatid cyst, it could represent a Hydatid cyst, and serology was positive. Serology is positive for Hydatid cysts in 60 to 80% of the cases. Now, Hydatid cysts can be classified by the WHO into 6 categories. The first 2 are active cysts, and the other are transitional forms between active and inactive, and those which are inactive. Category 1 and 2 are those simple appearing cysts. Category 1 is simple appearing. It usually is a unilocular cyst. You may demonstrate on ultrasound a double layer. You have to look for it very carefully surrounding the cyst. Category 2 is a multiseptated or a honeycomb-looking cyst, also active. Category 3 are those cysts which have floating membranes within them. We call it the water lily sign. These are transitional between inactive and active. And as you go on, these cysts develop solid components within them, and the more solid they appear, the less active they are. So this is category 3B. There are solid components within these cysts with the cystic components. Category 4 looks completely solid, and as they develop calcifications, they turn out to be inactive. Now, it is very important to divide the appearance of these cysts, because this will help you in deciding when these need treatment or not. Treatment is reserved for categories 1 and 3, and these more solid appearing and calcified cysts may only need observation. So with this patient, this is a category 1 cyst, and with ultrasound, you can see the double layers surrounding the cyst. This is a category 3 with the water lily sign, the floating membranes in the cyst. It looks very nice. And this is a category 2 or 3B, depending on the solid component of the lesion, with the daughter cyst and the solid component in the center. And this is a category 5. This will go only for observation. It's almost completely calcified. Now, Hydatid cysts can complicate. They usually expand where the less resistance is, towards the least resistance areas where they are located. Now, their complications are usually caused by compression, by erosion, and by adhesions to adjacent structures. They can cause necrosis and fistulations. This is a case of a 16-year-old female who has episodes of right upper quadrant pain, and she presents with fever and elevated liver enzymes. On ultrasound, there is a very well circumscribed lesion located in what seems to be segment 8 of the liver. There may be some acoustic shadowing here, maybe some calcification surrounding or in the outer regions of the cyst. No vascularity. Because of this, and serology turned positive. Because of this clinical presentation, we thought that there may be a fistula between the cyst and the biliary ducts. We send her to MRI, and MRI demonstrates again this cystic lesion. You can also see a thick and even a dual layer surrounding the cyst. You see this bright stripe surrounding and this black stripe here, 2 layers. And there's also upstream dilatation of the bile ducts, and if you look carefully, there seems to be a connection with the bile ducts between this cyst and the bile ducts here. She goes for left hepatectomy, and it proved that there was communication between the bile ducts and the Hydatid cyst. So Hydatid cyst with biliary communication. Here is another case of a 65-year-old patient who presents with epigastric pain, jaundice, and elevated liver enzymes. And he is known to have this cyst for almost 20 years but refused any treatment. But now he presents with this clinical presentation. And what was concerning was the bile duct dilatation surrounding the cyst. And with this clinical presentation, we thought that there may be connection. Now, the gold standard actually to prove connection is performing an ERCP. So we send this patient for an ERCP, which nicely demonstrates the bile ducts, but also shows spillage of contrast into the cystic structure, and this proves that there is a fistula between the cyst and the biliary ducts. Now here's a patient who presents, he's 35 years old, and presents with an incidental finding. In his liver, there is, again, a well-circumscribed liver lesion. It has solid components, it has cystic components, no vascularity, and one of the differential diagnoses did include Hydatid cysts. However, this patient is known to have neurofibromatosis 1. This was biopsied, and this turned out to be a plexiform neurofibroma. Now, plexiform neurofibromas are very rare in the gastrointestinal tract and more rare in the liver, but they can be seen in the liver because they tract along the nerve fibers going along the portal veins and into the porta hepatis. So you usually will see them around segment 4 or segment 8 of the liver, but they are very, very rare. Now, if we had not biopsied this and not know that this patient has neurofibromatosis 1, we could have thought that this maybe is a category 3B Hydatid cyst. This is a 68-year-old male who presents with a liver mass. At the time when we saw this, I had no clinical information. So I looked at this CT, and it demonstrates, following the administration of contrast, a low attenuation mass. It has maybe small cystic components within it. It enhances a little bit. The borders are irregular. And of course, there's a differential diagnosis for this. This could be a cyst biliary adenoma. It could be a cyst biliary adenocarcinoma. It could be a necrotic tumor. It could be a mucinous tumor metastasis, or it could even be a liver abscess. But once you get the clinical information and the clinician tells you, well, this patient presents with right upper quadrant pain and has fever, there's no doubt that this is a liver abscess, and this was a liver abscess. So my point here is that you cannot make the diagnosis of a liver abscess if you're isolated from the clinical information. clinical information is very important for diagnosing liver abscesses, because liver abscesses can have a very variable appearance. They can be of low attenuation, heterogeneous, look very solid sometimes. They may have multi-septations and what we call the cluster sign. And if they are left untreated, they will cavitate, they will contain fluid within them, and then they will demonstrate rim enhancement and some perifocal edema, and clinical information is very important to make the diagnosis. However, look at these two images. These are two completely different patients. Both present with very similar solid lesions or solid cystic lesions. They both are well circumscribed. They have solid enhancing components. They have cystic structures. And this was a neuroendocrine tumor, and this was a liver abscess. So knowing the clinical information, this patient had fever, leukocytosis, everything we know that a patient with a liver abscess should have. And this was a patient who was asymptomatic except for the symptoms produced by his tumor. Now, cystic metastases are very common in the liver, but usually they are solid. However, cystic metastases could be seen in the liver, and there are two mechanisms for them. The first one are those metastases which arise from mucin-producing carcinomas, such as colorectal carcinoma or ovarian carcinoma. And usually ovarian carcinomas, the metastases spread along the peritoneal surfaces. So they can spread to the liver surface along the visceral peritoneal layer, or along the diaphragm, along the parietal peritoneal surface. The other mechanism is tumor necrosis, and this is caused by rapid growth beyond the vascular supply of the lesion, and this is seen with neuroendocrine tumors, melanoma, and sarcoma. Now, this is a patient who presents with this liver mass. And on ultrasound, this mass is hypoechoic, but it has some internal echoes within it. It is very well circumscribed, but it has posterior enhancement. So it does have some cystic appearance or characteristics. She goes for an MRI, or before that, let's discuss the differential diagnosis. By looking at this, this could be an atypical hemangioma. It could be a liver abscess. It could be a cyst with debris. It could be a hemorrhagic cyst, or it could be a necrotic lesion. So looking at the MRI, on T2-weighted images, this lesion is very bright, light bulb. There are actually two things on MRI that can have this appearance, and that's a cyst or a hemangioma. Following the administration of contrast, this only slightly enhances. It doesn't enhance very much, so it's not a cyst. It's not a hemangioma because it doesn't have the characteristic peripheral nodular enhancement. This is not a hemangioma. This was biopsied, and this turned out to be a metastatic myxoid liposarcoma. And the patient did have myxoid liposarcoma in her thigh. Now, metastases for sarcoma to the liver are very rare. They are seen in 7% of the cases. If arising from the extremity, they are seen in 1%, and if arising from the retroperitoneum, they are seen in a higher percent. This is a patient who has metastatic TCC. He has this cystic lesion in his liver and received immunotherapy. Now, he comes in a few weeks later following the treatment, and we do the CT, and this cyst enlarges. Now, The enlargement of this lesion doesn't mean progression. It actually means regression. The attenuation decreased by 15%, and according to criteria, there is regression here. Now, the role of immunotherapy is to stimulate the immune system against tumor cells. What actually happens is, and in this case, the drugs that are used are called PD-L1. Now, what happens is that tumor cells have a protein expressed on them which is called PD-L1. And this PD-L1 causes the immune system to think that these tumor cells are normal. That's actually how tumor cells evade death. What these drugs do is that they block these proteins, and this causes stimulation of the T cells of the immune system against these tumors, and this causes necrosis, hemorrhage, and cystic degeneration, and that's why they look cystic following the treatment. Here is another case of two different patients. They present with polycystic livers. Okay, patient 1 and patient 2, the livers look similar. There are more cysts here. Some of them are of low density, some of them are of higher density. We know that cysts in the liver can have some proteinaceous content within them. They can hemorrhage, so they really can have different attenuations, but they look cystic. Concerning a little bit is the ascites in this patient. Now, remember that you will always find your answers in previous exams. That's one thing that we learned when we were young and residents at our early years. This patient had GIST. He had a gastrointestinal stromal metastatic tumor. And following treatment with Gleevec, which is also a new classified drug, these lesions become cystic. And they're changed from this solid to cystic appearance, even though they do not change their size and they do not disappear, does not mean that there is progression. This is actually regression. The cause for the ascites is because one of the side effects of Gleevec is fluid retention. It causes pleural effusion, pericardial effusion. So just remember that cysts following treatment of metastasis does not mean progression, it actually means regression. So complicated, there are no rules with cystic liver lesions, and a few things to remember. Although some things may look like ant mini, as this Hydatid cyst, remember that there are all kinds of ant minis. So although this may be the rule, there are always things which do not go by rules. The other thing is that it would be nice to have a Bosniak classification for liver cysts, but although we do use the characteristics or rules of Bosniak for many body parts, it doesn't always work. Remember that with the liver, simple does not always mean benign, and complicated does not always mean malignant. There are other things you have to look at. That's vascularity, that's bile duct dilatation. Sometimes you'll just have to biopsy them. There's no other way. And always remember, clinical history, symptoms, and lab results are always important. Thank you.